Good morning and welcome to the Region 1 ESC Project HEAL Cybermentoring for February. Today is February 8th, 2019, and the topic for today is going to be neonatal care. So first of all, I want to let everyone know that this is being recorded, and if you have any questions, students, you can either unmute and come and ask the question in person, or there's a chat feature. You can go in and type in your question in the chat area, and we'll take time to answer that. So I want to welcome everyone. I hope you're having a good day. It's a little bit chilly today, but we're going to hope for the sun to shine sometime later today. And first of all, I want to welcome a professor from South Texas College. Her name is Bima Johnson. So Ms. Johnson, you can take it away.
Hi, good morning to all. My name is Bina Johnson. I am an instructor at South Texas College. I teach nursing students. I'm so excited to be here. This is my first cyber mentoring section. So I am very excited to see you, and thank you so much being there. Thank you so much. And Dr. Christy also in my room. She's giving me all the support and the directions. And thank you, Ms. Gutierrez, for all the directions you've given me.
Happy to do it.
Thank you. So can I start?
Yes.
Okay. Are you all hear me?
Give us thumbs up, classes, if you can hear. Everybody thumbs up? Thank you.
Okay. So my presentation topic is Neonatal Resuscitation Program. And what is Neonatal Resuscitation Program, or NRP? That is the care of the newborn at birth. And the care providing is a team of members. They include doctors, especially they are trained for taking care of the babies, and nurses, those who are working in specialized ICU, and always there be respiratory therapist also. They are the one taking care of the airway and the oxygen. And I put a picture here, including they are ready in the OR, like an operation theater or in delivery room, and they are ready at the bedside to receive the baby. And these are the equipment, especially for the babies. They are small, so we need a special equipment. All the equipment will be like a small size. So we have a self-inflating bag here to provide oxygen, and this is bulb syringe. And this is a specialized equipment called, this one is called a laryngoscope, and this is endotracheal tube.
Ms. Johnson,
yes.
You haven't shared your screen, so we can't see the presentation.
I'm sorry.
It's okay. Give it a minute. It takes a minute.
Okay. I have to start from the beginning.
And while we're waiting, I want to welcome Mr. Cantu's class, Ms. Garcia's class, and Mr. Molina's class. Welcome to our cyber mentoring for February.
Ms. Gutierrez, I need to start again all over, right?
Yes.
I'm so sorry. I'm so sorry.
It's okay. Go down and share the screen. I'll tell you when we can see it. There you go. Now open the PowerPoint. Perfect. We can see it now.
Oh, okay. Thank you. Let me start again. I'm so sorry.
No, it's okay.
Yeah. Okay. So my presentation topic is Neonatal Resuscitation Program. It's called NRP in short way. And the care, that is the care of the newborn at birth. And who is providing the care? The specialized doctors, they are taking care of the babies, and the nurses, those who are working in the ICU, specialized ICU for the babies, And there will be respiratory therapist also. They are the one responsible for taking care of the airway and providing oxygen. And I put a picture here. They are in the delivery room or in the OR and staying at the bedside. The bed is like warmed up, that is ready to receive the baby. And here on the bed, there is some specialized equipment here, especially for the babies. They are so small and fragile. So we have to keep specialized equipment. There is self-inflating bag that is providing oxygen or air and bulb syringe. And these are two specialized equipments. The one with the handle is called a laryngoscope and the tube is called the endotracheal tube. And this is the bulb syringe to clear the airway. Sometimes when the baby born, they have some fluid in the mouth that obstruct the airway. So we can use the bulb syringe to remove the secretions to help to clear their open airway. And this is another equipment. It's called a pulse oximetry. So we go into, there will be like an probe attaching to baby's feet, small feet. So in the machine, in the oximetry, we can see their oxygenation. And this is also required in during the delivery. And this is the same bag I mentioned earlier. It's called a self-inflating bag. The one of the advantage for this bag is it's always inflated with air. In emergency, it is very convenient to use also. You can see the mask, oxygen mask attached at the end. And this is the bag and this is the oxygen reservoir also. I hope you guys are enjoying so far following me. And how often do we use resuscitation skills? So always need to assess the baby as soon as they're born. And the primary care is always need to keep the baby warm. So we need to warm up the bed and always keep warm up that blanket should be ready. And as soon as the baby born, the nurses place the hat on their head and make them cry to stimulate and dry. And sometimes when the baby born with the fluid, and so we need to remove the wet linen and provided we give them new dry linen. And some baby, they need like a back mask ventilation, those who are not able to breathe. And in case they need, their condition is changing, like becoming heart rate is dropping down, oxygen is going down, that baby needs chest compression also, then doctors will order medication also. And when you are ready to attend a delivery, these are the few questions as nurses, they are keeping in their mind. Clear of meconium. Meconium is the first poop or the stool baby is passing. If they pass the stool in mom's tummy, there is a chance baby will swallow, then it will go in their lung and they are not able to breathe. So always make sure that is it clear, there is no meconium, and whether baby is crying or breathing, and there will be like a good muscle tone. The baby will move their arms like the all extremities. What is the color of the baby? Is it pink? And how many weeks, like how many weeks the baby born? Why is it premature? So it depends upon the gestation. So these are the questions we are ready to ask ourselves. Apgar score, this is very important while you are assessing the newborn baby. Apgar score is used to assess newborns immediately following birth. It measures 5 areas at both 1 minute and 5 minutes following delivery. These are the 5 areas. Skin color. If we expect a baby is pink color, that if the baby's color is pink, the score will be 2. If the heart rate is over 100 beats per minute, that baby will score 2. And baby is breathing spontaneously, that is baby is good crying, the score will be 2. Muscle moving all extremities, that is score 2. And the response, that is sneezing or coughing, that is score. So if it's 1 minute, baby get 10 points, that baby is healthy. Some baby, they are not able to do that. The skin color will be blue, the score will be 0. And there will be no heart rate and breathing, their score will be 0. The muscle tone, they will be like limpy and flabby. They are not able to move their extremity. Then that baby also will score 0. And reflex response is there will be no reflex, no crying, no sneezing. That the score will be 0. And in case of the some baby, they will score 1. That baby's color, the body will be pink, but the hands and feet is blue. And there will be heart rate, but the count will be 100, less than 100 beats per minute. And breathing, sometimes they are slow breathing. Muscle tone, some movement, not like a strong movement. And reflex response, grimace, we can see their facial expression. It will be like a facialish expression will be showing some difficulty. They are in pain. So Apgar, appearance, that is the color, the pulse or heart rate, grimace, the facial expression, activity, the movement of the extremities, and respiration, that's the breathing. So what are the initial management for all deliveries? Provide warmth. That is the most important thing. We have to maintain the temperature by keeping the bed ready, providing the extra linen, warm cloth, and providing the hat. And second one is position and clear airway, and keep the baby dry. Remove the wet linen and provide them new dry linen. And some baby, they need oxygen, so we have to ready for the oxygen. Breathing or crying. Indications for PPV. PPV is the positive pressure ventilation. Some baby, they are not breathing. They have difficulty to breathe. Or some baby, the heart rate is less than 100. And we giving oxygen like 100%, still the color is not good, like a pink, they have a blue color. In that case, we're going to give PPV, giving some support. So this is one of the very advanced machine equipment, neonatal puff. So we can use with the self-inflating bag, the one I showed you before, or you can use this neo puff also. You can see the meter here, so we can adjust the pressure. Then this is the connection for the oxygen. Here is the connection for the pressure. And the mask is here. So this one is very convenient to use in during delivery, those baby needs like a PPV. And there is different oxygen masks. You can see very small and different sizes also. We use different size for the baby. And the small one is for the preterm baby, those who are born early. And make sure the babies, here the PPE, the infant's heart rate is 40 to 60. So first important thing is we need to clear their airway. And you can see the nurse is holding the baby's jaw. So we have to keep like a sniff positioning, not hyperextended. And have you seen the nurse's hand is like a C shape, and here is letter E. So this is the correct way to keep the baby's mouth and covering the nose and the jaw. So it's sniffing position, not hyperextended. Indications for intubation. Intubation is a procedure using specialized equipment, either one laryngoscope and endotracheal tube to give additional support for breathing. Meconium, if baby have a meconium and baby is not active, that is vigorous. And we given PPV and baby is not showing the chest rise or much not improvement in the baby's condition. And the PPE we given more than 30 seconds and chest compression necessary. So we have to intubate the baby. And epinephrine is one of the medication we do giving during the resuscitation time. So these are the blade. This is the handle for the laryngoscope, and these are the blade. You can see the 0 is the small one. Number one, we usually for the term babies. And these are the different types of endotracheal tube also. This is called a stylet. It's kind of a straight. So it will go inside the tube. So it will help to easy intubation, to pass the ET tube through the trachea easily. And this is the technique, the positioning. What happened? Okay. So this is when done the intubation. Some baby's heart rate is less than 60, so we need to, less than 100, we need to start compression, chest compression. So we use our two thumb around their chest wall, start compression. So the procedure, the technique will be like a 4 events 2 seconds. So the thumb on the baby's sternum, that is the breastbone, then we going to push hard. So the lower part of the bone, it will go and touch the heart that's started to pump. So it will pump blood to all over the body, especially to brain. So the sequence will be 1, 9, 2, 1, 3 and breathe. Those who are providing the compression, they have to say louder. So 1, 9, 2, 1, 3 and breathe. So those who are bagging using the bag, so they have to give one breath. 1, 9, 2, 1, 3 and breathe. 1, 9, 2, 1, 3 and breathe. So we will continue that skill for 1 minute. So within 1 minute, the baby will receive 90 compression and 30 breath. So this one is indicated when the baby's heart rate is less than 60 beats per minute after we given the positive pressure ventilation. I hope you all are following me. Is that correct?
Yes. I have a moment I want to ask Ms. Garcia Molina and Cantu's class.
Yes.
If any of you have questions, make sure that you go to the chat feature of the Zoom platform and put in your questions.
Okay.
Thank you.
Okay. So once we continue that skill, the compression for 1 minute, then we can see like a miracle change. Baby's color will be getting a pink, oxygen saturation will increase, usually above 88 or above 90, and baby's heart rate will be higher, above more than 100 beats per minute, and baby started to breathe. In that case, doctor will assess and order to stop the resuscitation. So if the baby is healthy, the color is pink, we can remove the resuscitation and give the baby to mom or transfer the baby to a regular nursery. Rarely, some babies, they need additional help. That baby will require transfer to like a specialized NICU, like a specialized intensive care, that is NICU for additional support. I think I'm done with the presentation. So this is the baby. So happy with the mom. You can see the color, it's pink. And mom also happy. And there is some resources I given. So this have very valuable, this is a valuable resource. You get so much information from this side. I think I'm done with my presentation. I hope you all enjoyed it. You all enjoyed it?
Thank you. Go ahead and stop sharing your screen.
Okay.
And I'll take a minute to see, do any of the students have questions for Ms. Johnson?
Okay, thank you.
Mr. Cantu, Molina, Garcia, any questions? I don't think that we do. Ms. Johnson, thank you very much for your presentation and letting us know about neonatal care.
Oh, thank you, ma'am. Thank you for giving me the opportunity. I really enjoyed it. It is a different learning experience. Thank you.
Oh, you're more than welcome. So next, we're going to turn to Doctors Hospital at Renaissance. And I believe we have Ellie Almeida. Is that correct?
That's right.
Yes. Well, we're very pleased to meet you. I'd like to present Mr. Cantu, Ms. Molina, Ms. Garcia's class, plus we are recording this, so there will be other classes in the future who watch the video. Welcome.
Thank you so much. So, as she said, my name is Ellie. I'm the NICU and the nursery educator here at VHR. I'm gonna tell me just really quick. I was born and raised in Brazil. I did my nursing school in Brazil, then moved to the US, was a nurse here, and started working. I worked before, and then I moved to the NICU, and I loved it. It was a passion at first sight. And I worked as a NICU nurse and as a charge nurse for several years, and now I'm the educator here at VHR. So we're going to be talking a little bit about neonatal resuscitation program today, you guys feel free to ask any questions anytime, okay? I'm just going to show you really quick some of the equipment that we're going to be using. So when we're getting ready to a delivery, any delivery, okay, we have a few questions to ask, right? Is this baby a term? Is this baby, is it only one baby? Is it a single pregnancy? Or what is the color of the amniotic fluid? That tells you a lot, you know, if it's meconium stain, or if to see if the baby was in distress or not. So we start to get ready. So if we anticipate that there's going to be needs for immediate resuscitation, of course, we call for additional help. We have a neonatal team that's going to be there, which is your neonatologist, your neonatal nurse practitioner, usually the charge nurse, RTs, specialized nurses will come. Okay, so we can prevent a lot of problems if we are totally ready and prepared to receive that baby and provide the needed intervention. Okay, so this happens to any delivery, right? We kind of anticipate, but sometimes everything seems really well, but as soon as that baby comes out, that baby still needs help that we did not anticipate. Okay? So you have to kind of like be ready all the time. As soon as that baby is born and you notice that something is not going according to expected, you have to call immediately for help. Here in the hospital, we use the sound system, the overhead system, that we have a number to call. We call code white, which is your code blue for adults. It's your code white for babies, okay? So the NICU team can come and assess the situation and get started with interventions. Now, as soon as that code is resolved, we also have to call a number and give the case as resolved. And we always look back to see if we did everything absolutely correctly and what we could have done differently, okay? So I'm gonna show you today some of the equipment. So for any delivery, you need to have suction, okay? Babies are usually born with a lot of secretion. In utero, the baby's lung is filled with fluids. The baby doesn't breathe in utero, okay? So, of course, baby's getting oxygenation from mom's blood and everything, so there's no need for the baby to breathe, right? So as soon as that baby is born, that baby transition from a fetal circulation to a newborn circulation. The baby takes the first breaths, and that fluid that was in the lungs starts to get filled with air, okay? So all that fluid, it's gonna get reabsorbed within hours, okay? So initially the baby might have a lot of oral secretions. The lungs might sound a little bit wet, so we have to be ready to intervene. So we always have suction available. A bulb syringe. Usually as soon as babies are born, you're gonna suction the mouth, gonna suction the nose. We also always have an ammo bag, and we have different types of ammo bags, okay? We have, this one is a self-inflating bag. which you don't need an oxygen source, okay? This bag will self-inflate and provide that air, so you don't need an oxygen source. And this one, it's a flow inflating bag, which you need to have connected to a flow oxygen, okay? So we try whenever we can here in the hospital, we try to use this one. And then we have in the baby's cribs, we have the self-inflating, because if you're not in an area where you have access to oxygen, you can use this one, okay? So we're gonna talk about a little bit about PIP and PEEP, which is the inspiratory pressure and the expiratory pressure, okay? So your ideal numbers for your PIP is you should be starting at 20, and the PEEP is 5, which is the pressure that's gonna keep the lungs open and not allow the lungs to collapse, okay? So you have to regulate this, okay? I'm not gonna be able to show you today because we don't have an oxygen source here, but just so you know the difference in the mass, okay? And then we have, which we don't use here in this hospital, is the Neonatal, which you would also regulate, and you would be able to give that pressure as needed, okay? We also always have the instrument to intubate the baby, okay? But obviously, this is gonna be baby size, okay? This is a blade size 0. You have a 00 for the really, really tiny micro preemie babies. And then you have each tubes available. Your tube that you're gonna be intubating, this is a 2.5. You see how small it is? We have it in 2.0 tubes. And then you can have, you see the mark where to tape. So one of the things that we always say, like, are you just going to put this tube in and I'll go all the way in? You can't do that, right? Because you're gonna hurt and possibly perforate the lungs. So a good measure that we use, we estimate the baby's weight, usually by weeks of gestation. Of course, in an emergency, you're not going to be weighing first thing. You want to be make sure that you're attending to the baby's needs first. So you kind of estimate the weight, and then we add 6 to it. It's just so if you estimate that it's a 2-kilo baby, you're just going to take that 8, which it would be right there, okay, at the lip level. We need to have medications available, okay? A medication that we use commonly when your first steps of intervention are not resolving, not helping the baby, is the epinephrine, which is going to increase the heart rate, increase the contractility of the heart. This is something that we always say, like, to be very careful, because babies dose and adult dose, it's very different, okay? Adult dose is 10 times more powerful, and it could be very dangerous to give it to a baby, okay? So when you open this package, what you're gonna see here is gonna come like this. And basically what you have to do is to remove this yellow part and just screw it in. And you can get a syringe and get exactly the dose you need here, or you could go straight with the needle in here and just aspirate as much as you need, okay? So baby dose is, if you're giving via each tube, the endotracheal tube, you're gonna give 0.5 to 1 mLs per dose, okay? If you're giving via umbilical vein, you're gonna give 0.1 to 0.3. Just remember that when it's through the HEAL2 tube, you're gonna go with the highest dose first, just because it takes much longer for the body to absorb than it would be in through the vein, okay? Talking about the vein, so babies are born with 2 arteries and 1 vein, right? So you wanna make sure that you locate which one is the vein and which one are the arteries, okay? The vein is gonna be usually the thicker, the caliber is just bigger, okay? That's the one you go to. There is a whole measurement that you use for ideal location, but in case of emergency, you usually introduce about 2 to 4 centimeters, or just until you get blood return from the vein, and then you're good to go and give your medication, okay? So you usually start giving your medication via HEAL2 tube, but as soon as you had to give that dose via HEAL2 tube, you need to start getting prepared for the placement of the UVC, umbilical venous catheter, okay? And this is what the umbilical, the UVC looks like. We have different sizes as well. I believe this is a 2.5. And then you're gonna go just locate the vein, which is gonna be the thicker one. Of course, I would have a gown, sterile gloves, and all of that, right? And if I was really putting that into a real baby, right? So you just go in, and then you check for blood return. We're gonna put everything together in a little bit. I'm just showing you the different components, okay, of the neonatal resuscitation. And for our NRP classes, we've been using this mannequin, which is the Sing Baby. And it's pretty amazing, okay? We can even really get blood, which obviously is not blood. You see, there it is. So we're in, okay? And not only that, but after, if the baby is still not responding after medications and everything, you have to think maybe this baby is in shock, you know, volume depleted. So the 2 volume expanders that we can use for the babies, it's normal saline and O negative blood, okay? In an emergency, you're not gonna have time to type and cross-check exactly what kind of blood the baby is and all that. So we can use O negative blood in an emergency, okay? You wanna put, as soon as you can, a pulse ox. We have this pulse, there's different kind of pulse oxes as well. We have this one that comes with a simulator. The most common that you're gonna see in hospitals is gonna be this side. It would just wrap around the baby's right hand, which is gonna be your most accurate reading, okay? It's your preductal blood, but that's a whole different class. So we're not gonna go into that. But, and then you have the leads as well, which is gonna be showing your heart rate, your respirations, okay? So this, so you don't have to be stopping all the time to auscultate the baby. You wanna place this as soon as possible. Now, until you have this, obviously, you want to auscultate the baby first, okay? Before, they would say it was fine to check, because if you actually press around the umbilical cord, you can still feel the pulse in the baby. But now, the most recommended method for auscultating, for actually checking the heart rate, is through auscultation. And then as soon as you can, you place the leads, and you can continuously monitor the baby in the monitor. So you would see heart rate, respirations, if you check your blood pressure, and how much oxygen the baby is breathing. Now, what is the normal O2 sets for a baby? If I get any of you healthy young people, you should be saturating anywhere between 97, 98, 99, 100%, right? A baby, as soon as the baby is born, it's normal to have a low saturation, okay? Remember, there's a transition period. If you get 60 to 65%, it's okay. And then you can expect for that to increase 5 to 10% by every minute, okay? So by around 5 minutes, that's when you would expect your baby to be saturating the 90. So there's really no need to freak out in the beginning, thinking that baby needs oxygen as soon as possible, as long as the baby is not struggling to breathe, and as long as the baby is actually breathing and active, it's fine. You just wait, and that saturation should pick up, okay? The problem is when your baby is not breathing, when your baby comes out just floppy, no tone, okay? That's when there's no chest movement, okay? And the best way to check for breathing is through noticing if the chest is rising or not, right? So as soon as you see a baby that's floppy, that is not breathing, that's when you need to start acting right away, okay? So when you intubate a baby as well, you need to check if the ET tube is in the right place, okay? So one of the ways that we use is a CO2 detector, which is just gonna pick up, if it's in your lungs, you should have carbon dioxide, and it should change the color in the sensor here. Sometimes if the babies are too small, they don't have enough concentration of CO2, this might not turn colors. So the best way to really check if it's there or not, it's auscultation, okay? Where do you intubate? I found this little model. This is definitely not a baby, okay? As you can see, there's a full set of teeth here. But I just wanted to show you, as soon as you put your laryngoscope in the baby's mouth, what are you looking for? Where is the correct place to intubate? So here you see the tongue, and then we have two tubes, right? One that goes to the lungs, okay, it's the trachea, and one that goes to the stomach, which is the esophagus. So the esophagus is going to be lower. So you're looking for this marks here, okay, which is going to be your vocal cords. Can you see well there? Mm-hmm. So your tube should be going right in the middle of your vocal cords, okay? So this is what we see when we put the laryngoscope in, okay? Okay, so now let's get to the practice of this. So usually you're gonna have a team of people, okay? You're gonna have one person just to do chest compressions. You're gonna have one person just to bag the baby, give the PPV. You're gonna have one person drawing up medications. You're gonna have another person that's gonna be coordinating everything, and you're gonna have a person just recording the event. So we have the tendency to think, you know, recording the event is not that important. It's one of the most important things, okay? Because after the code is all done and resolved, the only thing that you're really gonna have to tell you a story is that documentation, okay? So the documentation should be very detailed. It asks you who was in there. It gives you all the fields that you just fill it out, but basically just writing down exact times, what was done at that time, what's the next intervention and everything else. So it's really important for the team to be communicating really well, okay? Because you might have a very effective team as far as interventions, but if they're not communicating well, the code is not gonna go well, okay? So whoever is doing, giving medication, needs to be saying out loud, this baby weighs 2 kilos. I'm giving 2 mLs of epinephrine via the HEAL2, okay? So this way the recorder can hear and can write down appropriately, okay? If you're just doing and giving and not saying anything, the recorder is not even going to put anything down, because there's usually a lot of people around the baby. The recorder is back there. So it's really important to communicate well, okay? So let's say this baby, I'm gonna give you a little scenario. So let's say this mom was in a car accident. She's 37 weeks, 37 weeks is already term, okay? 37 weeks and on is considered term. So the baby's term, so this baby weighs about 3 kilos, let's say, but this mom was in a car accident, so she's bleeding a lot, okay? So they call overhead for an emergency. So the NICU team goes, everybody's there, ready, the baby is born, baby's floppy, pale. You see that the baby's cyanotic here. And then somebody starts to dry up and stimulate. Those are always the first steps, okay? Drying up the baby, stimulating. Sometimes just with stimulation, the baby comes back and they start breathing. But in this case, this baby is not doing that. So somebody immediately will grab the bag, and the correct place to put this. So this pointy part always goes to the top of the nose, okay? And it needs to cover the baby's nose and the baby's mouth. So you put at the top of the bridge, the 3 fingers stay on the baby jaw to give support. And then these 2 fingers form a C, and you just press down, okay? As your instructor said, the head cannot be over hyperextended, okay? And then if you have the head too curved, you're gonna be blocking the airway as well. So sniffing position is the best way. Baby looking up, eyes facing the ceiling, okay? And you just press the mask down. This is very soft. You're not gonna be hurting the baby, okay? Just press it down, and you wanna give breast. If you're gonna start giving breast, the one that, how often do you give it? So one thing that we use to guide us how often we're gonna bagging the baby is breathe, 2, 3, breathe, 2, 3, breathe, 2, 3, breathe, 2, 3, breathe, 2, 3. You see that the chest is rising here? This is the only way your PPV is going to be effective. If you see that your chest is rising. If it's not rising, you need to perform corrective measures that we call Mr. SOPA. Okay, it's an acronym that stands for M is your mask. So you're going to try to reposition the mask. Let's say that my ventilation was not effective here. I'm not getting a chest rise. So M, you're gonna try to reposition the mask, try to get a good seal again. Usually you lose the seal around the nose. So you really wanna make sure that this is well sealed there. So you reposition the mask, okay? I'm getting a chest rise, but let's say it wasn't. So the next one for the Mr. is the R. You're gonna reposition the baby's head, okay? Try again, sniffing position. So, but this is all happening very fast, okay? So it did not help. SOPA is gonna stand for S, suction. So you would try suctioning the mouth and the nose, okay? Mouth first, and then the nose. O, you would try opening the mouth. P, in the case of you're using the flow inflating bag, you would increase the pressure just a little bit. Sometimes the baby's lungs is very resistant, so you might need a little bit more pressure to open that up. So you could be going up to 30. And then if you did all of that and you're still not getting a good chest rise, you would need an artificial airway, which is going to be your intubation, okay? So let's say in the first 15 seconds, you're going to be assessing all of this. By 1 minute that you're trying to, if you're getting good PPV and your baby's heart rate is still less than 60, that's when you have to go ahead and intubate, okay? As soon as you intubate and you have your heart rate is not going up, you need to start doing chest compressions, okay? So chest compressions, we use about the two thumb encircling technique, which is gonna be right at the nipple line. So you just do 1 and 2 and 3, and whoever has the airway here would do the breathe, okay? 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe. As per new NRP guidelines, we always intubate first prior to starting chest compressions, okay? Meconium babies, before they would just intubate, as soon as those babies would come out and they were not breathing, they would intubate right away, try and suction the meconium out. They did away with that now. They treat meconium babies like any other baby. You can go ahead and stimulate. You can go ahead and try to suction. And then if none of that helps, then you're gonna go ahead and intubate, okay? So let's say I have my poor baby here, it's still in the 40s, even though like I'm doing my PPV. I did my PPV for the minute. See, I'm getting good chest rise there. So breathe, 2, 3, 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 breathe, 2, 3. My poor baby's still heart rate in the 40s. So what I'm gonna do next is I'm gonna intubate, right? Let's say so, and by the way, nurses usually do not intubate, okay? This is usually done by the neonatologist or the nurse practitioner. We just teach what is the correct way to do it. Some hospitals do allow nurses with a lot of experience to intubate, but here at the HR, no, okay? But as per NRP guidelines, we just teach what is the correct way to do it. Then you check your placement for, let's say this is turning collar. Somebody checked if there's good breath sounds in both lungs, everything is fine. So somebody's here, breathe, 2, 3, breathe, 2, 3, breathe, 2, 3. And then somebody else is gonna start doing chest compressions. Then you're gonna move to 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. So we're doing that for additional 30 seconds. Heart rate is not going up. Somebody's already drawing up medication. So this baby was 3 kilos. We're gonna go with the highest dose of epinephrine, which is gonna be 3. It's 1 ml per kilogram. And you're just going to give the medication via HEAL2, okay? So just push it down. At that point, somebody's already thinking we need to place lines, and then nurses will start drawing up medications, another dose of epinephrine. You usually wait 3 to 5 minutes between doses. But if you had a epi given via HEAL2, and now you have a UVC, you do not have to wait for the 3 minutes, okay? You can give it right away. So this poor baby is still hanging in there, not really improving. We're gonna go ahead and give epinephrine via the umbilical line. Nothing is happening. Remember I told you that this baby, the mom was in MVA, So the baby lost, the mom lost a lot of blood, right? So this baby is most likely blood volume depleted, okay? So 3 kilos, we can give 10 mLs per kilo of volume expander. So draw up normal saline, 30 mLs, and you can slowly give via umbilical line. It's a slow push. It would take probably around, somewhere around 10 minutes to give all of this. And now, all of a sudden, your baby starts to respond, because that's usually, you know, sometimes that's all they need is fluid for the circulation. Sometimes it is a respiratory problem, so proper ventilation should help. And now we have our little baby there with over heart rate greater than 100. So in this case, we would be able to extubate this baby. If the baby is still like struggling to breathe a little bit, what we do is we can just ventilate the baby with a mask. Okay, in this case, we use the flow inflating mask, and you just want to keep it. You don't need to bag, but you just keep it pressed down to the baby's nose, and that's going to be giving the PEEP, which is the expiratory pressure that won't let the lungs collapse. Okay, this little pressure is just going to help the lungs be a little bit inflated to help the baby. Okay, you would transport the baby to the NICU just with the mask sealing the baby's nose and mouth. See that the baby is moving now, so we saved this baby. Yay. Okay, so this is just in a nutshell what NRP is. I wonder if anyone has questions for me.
Let me see. We have several classes with us now.
Okay.
Students, if anyone has questions, you can either come up to the computer and unmute and ask your questions, or type it into the group chat. So I'll go class by class. Miss Molina's class. Hi, how are you guys doing? Hello.
Hi.
Hi, does anyone have any questions?
Don't be shy.
Not right now?
I don't know.
Okay, thank you. Miss Elizondo's class, hello. Hi, guys. You can say hi, we can hear you. Does anyone have any questions?
Could you perhaps show a model for the trach tube?
Ask again, Mr. Cantu.
That if you would kindly re-show the model when she was trying to intubate the baby.
Right. Oh, you want to see the model again, the intubation model?
Yeah, there was a question about the anatomy to differentiate between the esophagus and the trachea.
Question in anatomy to differentiate between the esophagus.
Okay, so you see here these landmarks, the two little membranes on the side of the hole, okay, the top hole. That's, so the glottis is there, and then you can see that you have these little membranes here, which are your vocal cords. So you want to go right in the middle of that, okay? For babies that we usually have to intubate in the NICU that are vigorous, but we have to intubate for any reason, one of the first things that you're gonna see is like that baby's crying. As soon as you put that tube in, the baby won't be able to cry anymore because you're going right in the middle of the vocal cords. You're obstructing that way, okay? So we're like, yep, it's in. You don't even need to auscultate like we still do, okay? But you know that it's in because it's the baby stopped crying, okay? But in this case, like if we have to do NRP, most likely the baby won't be crying, right? And then the bottom tube is just a hole. You don't have landmarks basically. So sometimes if you go in too far with the blade, the first thing you're gonna see is the esophagus. So if you don't see the vocal cords, you have to just come out a little bit further in order to see the vocal cords and the trachea. So that's exactly where you would go. It's right there. Okay. I don't know if you guys
Tinier than that.
There we go there. Okay, there we go.
Any other questions, Mr. Cantu, from your class? Don't be shy, guys.
I have a question for the training mannequin that you were using. You know how it was showing vitals and whatnot, and the second that epinephrine was injected, is this real medication that we're playing with, or how does the system know when, you know, the doctor or the trainers have injected certain medications or have done certain practices to raise the baby's heart rate and whatnot?
Yeah, so the mannequin, obviously, when there's no technology so far that could really imitate, you know, a baby receiving real medicine or just like a placebo, or in this case, we're just pretending, okay? There's no way. What we do is we follow the guidelines. So when we're teaching the students, we basically are looking to see if they're doing everything correct in the steps described by NRP. And if they do, this is the simulator, okay? This is the computer. And we can control here if this baby is gonna be flaccid tone, if it's gonna be active, if the baby is gonna cry. Let's make the baby cry for them to hear. Okay. See, so usually when they do everything correctly, all the steps, and obviously these are nurses that study for this class, right? So, you know, we allow for where we control the simulator to react for this baby to start crying and moving and all that. But unfortunately, so it would be great if somebody could come with a technology that would allow for the simulator to recognize correct dose of medication and all that. But unfortunately, it doesn't work that way. We're just making sure that they know how to draw up medications, that they know how to give, when to give, and following the correct steps.
Okay. The medication will read the dosage that was given, but it won't read the medication itself.
Yes.
So it will read the dose of medication to make sure that the nurses are giving the correct dosage by the injections. It just does not read the type of medication given unless we put some, they're called RFIDs, and they're located around the mouth and the umbilical. So if we put an ID tag on the medication and put it close to those locations, it will read what medication we've typed into it for that dose.
Mr. Cantu, they have electronic markers, and when they put those markers near certain points on the baby, it'll read that. And they can program all of it. It's amazing.
Yeah.
Any other questions? I want to give Ms. Garcia's class a chance. Ms. Garcia, do any of your students have questions? Oh, I see she already put no questions. Well, I want to thank our guest today, Ms. Johnson from South Texas College, and Ms. Alameda from Doctors Hospital at Renaissance. Thank you very much for joining us today. It's been a wonderful session. I know that this is probably the #1 topic I have students tell me they want more information on is neonatal care. So thank you very much for joining us today. Students, thank you very much for joining us, and we'll see you next month. Bye.
Thank you.
Thank you. Thank you for your participation. Thank you. You have a great weekend. Thank you so much.
Thank you.